Good morning. I'm going to present the clinical meet from Pediatric emergency team on acute viral bronchiolitis. Since there's a recent surge in acute viral bronchiolitis by RSV worldwide, we have chosen this topic. Our learning objectives are supplemental oxygen therapy and pharmacotherapy in acute viral bronchiolitis. Invasive and non-invasive mechanical ventilation is beyond the scope of our discussion. So we have an index case, Master D, who is a 7-month-old boy from Kudalora, Chandigarh, admitted in ER from 16th to 21st of October. He presented with complaints of cough for 2 days, fever for 1 day, and difficulty in breathing for 1 day. Presenting illness, the child had cough for 2 days, which was a dry cough, non-paroxysmal, associated with post-acid vomiting, fever, which was high grade, maximum documented of 102 Fahrenheit, intermittent, and no diurnal variation, which was treated with medication. Respiratory distress was in the form of increased rate and efforts. However, there was no history of noisy breathing, loose stools, abdominal distension, poor feeding, cyanosis, abnormal body movements, and altered sensorium. Antenatally, there was no significant history. Child was a term baby, born by normal vaginal delivery, with birth weight of 2.5 kg, appropriate for gestation age, cried immediately after birth with smooth marital transition. He was second born to non-consanguineous married couple, and there was no similar history in the siblings or family members, and no family history such of atopy. He was immunized till age and attained all milestones up to age. So when his child presented in triage, so airway was open and stable. Breathing, he was tachypneic with respiratory rates of 74 per minute. Subcostal and intercostal retractions were present, and air entry was decreased bilaterally with bilateral V's present. On room air, he maintained saturation of 94%, which improved to 99% on nasal bronchs. Heart rate was 138 with sinus rhythm. Both central and peripheral pulses were palpable. CFT was within normal limits and BP between 50 to 75th centile. He was neurologically normal and febrile on exposure. Hence, a final categorization was level 2 emergent with respiratory distress. On general examination, anthropometry was well preserved with no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema, and other vitamin deficiencies. On systemic examination, respiratory system, the child had hyperinflated chest with hyperresonant node on percussion. Rest of the systemic examination was within normal limits. So we have a clinical database, a well child with no perinatal risk factors, no family history of atopy, no underlying congenital heart disease, with age less than 1 year, presented with acute febrile illness and respiratory distress, and on examination had bilateral hyperinflated chest with bilateral V's. So UNI's probable diagnosis was acute viral bronchiolitis. And this was the X-ray done at the time of admission, where there was peribronchial thickening, hypertranslucency, and hyperinflation. And the blood gas at the time of admission was normal. And the child had a following course in emergency. For respiratory distress, the initial assessment score for bronchiolitis, that is the RDA score, which comprises of respiratory rate, use of axillary muscle, and cyanosis. So it was amounting to 7, which is about moderate bronchiolitis. And hence this child was started on nasal bronch oxygen with a minimum of 2 liters per minute, which was again increased to 4 liters per minute due to worsening distress. On day 2 of admission, the score increased to 9, which was severe, and hence respiratory support escalated to HFNC at 2 liters per kg per minute with 40% FiO2. So till day 4 of admission, child was on HFNC support, and subsequently symptoms reduced and distress settled. And on reassessing, the RDA score became 7, and then subsequently fell to 5, and hence the child was again weaned off to nasal bronch oxygen, and there was subsequent decrease to 3, and hence the child was made on room air and he was comfortable on room air. For intermittent V's, the child was given nebulization with hypertonic saline on need basis. Child was started on ceftriaxone on day 1, which was continued till 2 days and was stopped after blood culture turned sterile. And the child was discharged after 5 days. So on investigations, there was neutrophilic leukocytosis and serum biochemistry was normal with CRP being negative. Nasopharyngeal swab for RSV PCR turned out to be positive. And blood culture sterile. And let us move on to the discussion on acute viral bronchiolitis. So acute viral bronchiolitis is defined as an acute inflammation, edema, and increased mucus production, which leads to necrosis of epithelial cells and thereby leading to airway narrowing and bronchospasm. Clinically, it is defined as so any child within 12 to 24 months or less than 12 to 24 months with first episode of wheezing and examination finding consistence of respiratory viral infection and other causes of wheezing ruled out. Initially, the child will present with respiratory prodrome like cough, coryza, and fever, which is followed by rapid breathing, retraction, wheezing, poor feeding, lethargy, and irritability. And the signs elicited are tachypnea, tachycardia, hyperresonance, wheeze with crackles, and push down liver or spleen. So this was a severity assessment score in bronchiolitis, which we used in our index case, modified respiratory distress assessment score, where the clinical parameters include a respiratory rate, use of axillary muscles, cyanosis, and auscultatory findings. So in our index case, the score was the respiratory rate was more than 70, axillary muscles, 2 axillary muscles used, the cyanosis, there was no cyanosis, and auscultatory findings with decreased air entry, which made up a score of 7 and classified as moderate severity. So what could be the other diagnosis in a child with similar presentation? So pneumonia, which can be ruled out with persistent focal crackles and grunting, viral induced wheeze or early onset asthma, where there will be persistent wheeze without crackles and recurrent episodes, and there will also be any history of atopy. In pertussis, severe paroxysmal cough may be present. In the absence of URI, we must definitely rule out cardiac disease, airway anomalies, and foreign body aspiration. So in case of bronchiolitis, so the virus infects the epithelium and causes necrosis of the epithelium, and which leads to inflammatory reaction and mucus production and causing airway narrowing. So it is predominantly inflammatory action, and we have to give a respiratory support or any adequate support till the reaction resolves. So respiratory support is the main modality of treatment for acute viral bronchiolitis, which can be in the form of low flow oxygen therapy with nasal prongs or face mask, HFNC, which can provide up to 2 to 3 liters per kg per minute, maximum of 60 liters per minute. But at 3 liters per kg, it is found to be cause more discomfort with similar failure rate. And CPAP. So when should a child be intubated? So if there is severe respiratory distress, there is gasping or bradypnea, and inability to maintain saturation of more than 94% on any respiratory support, cyanosis, CNS, and severe signs of hypoxia. Supplemental oxygen therapy. So all hypoxemic infants with saturation of less than 90% or 92% in non-threatening manner can be given supplemental oxygen in the form of free flow or face mask or nasal cannula. So oxygen can be discontinued if saturation of 90 to 92% is maintained and child is having minimal distress and feeding well. So next is HFNC. So there is a simple mnemonic for knowing the functional aspects of HFNC. H for providing heated and humidified gas. I, as it can meet elevated peak inspiratory flow demands. F for increased FRC like due to delivery of PEEP. Lighter as it is more easily tolerable than CPAP or BiPAP. O as it can minimize oxygen dilution. And W for washout of dead space. So a randomized trial between two groups, in one group where there was use of high flow oxygen therapy and another group with standard oxygen therapy. The primary outcome was escalation of therapy. However, only 12% of high flow group had escalation of care, whereas there was 23% in standard therapy group. And out of 167 infants, 61% had a good response to high flow rescue therapy. And hence, use of HFNC should be reserved for escalation of therapy if standard oxygen therapy fails. Next is CPAP. So CPAP causes opening and splinting terminal bronchioles, which leads to decreased airway resistance and air trapping. And it also causes recruitment of collapsed alveoli with decreased work of breathing, and it prevents escalation to invasive mechanical ventilation. So another study by Tramontane, where HFNC versus CPAP was considered, where there was standard CPAP used. It found that CPAP will decrease the duration of hospital stay and faster recovery when compared to HFNC. So CPAP can be considered in severe bronchiolitis, but it is in case of standard CPAP which is used. So this is approach to use of HFNC adopted from Lancet. So when a child is admitted to a hospital with bronchiolitis, so we have to initially start on supportive care. And if the child is hypoxemic, then we have to commence on low flow oxygen initially. And if the child responds, then we can titrate and wean off. But if there is increased requirement of oxygen and the child does not respond, then we have to go on for HFNC. And if the child responds to HFNC, then we can titrate and wean off as per the requirement. And if the child doesn't respond, then we have to escalate in care and go to CPAP. And how to assess response? So if there is decrease in respiratory rate, heart rate, or severity within 4 hours of therapy, then the child is said to have a good response. And in infants within 6 months, CPAP seems to be a better option than HFNC, which is a standard CPAP. So what could be the order of respiratory support which we can be used? So in case of mild to moderate bronchiolitis, we should try with simple nasal prongs initially. And if there is worsening on simple nasal oxygen, then we have to consider HFNC on CPAP. So as we have already seen, HFNC has provides a good support compared to supplemental oxygen. And in case of HFNC and CPAP, the studies are always equivocal. So in a resource limited setting like ours, where we do not have a standard CPAP therapy, then what can we do? So hence our unit has done a study where indigenous bubble CPAP which we use has been compared with HFNC in under 5 community-acquired pneumonia population, where it was found that infants with acute bronchiolitis, they perform better on HFNC as compared to our nasal indigenous CPAP, and hence had a faster resolution of respiratory distress. Now let us move on to pharmacotherapy. So hypertonic saline, which we commonly use in acute viral bronchiolitis. So it reduces mucosal edema and causes osmotic flow of water, and hence reduces mucosal viscosity and enhance mucociliary clearance in the airway. So studies have shown that hypertonic saline reduces the hospital stay by 10 hours in comparison to normal saline, and hence it can be considered in inpatients, and it can be given as and when required. Role of epinephrine, according to review by Cochrane, so it has been found to be beneficial in outpatients where there is significant reduction in admission rate at day 1. However, in inpatients, there was no such significant response. Hence, it can be used as a rescue measure in critical cases. And literature suggests that there is no role of bronchodilator in the first episode, corticosteroids, antibiotics, antivirals, chest physiotherapy, and steam inhalation in acute viral bronchiolitis. So maximum of 173 infants have been admitted in our unit from November 2019 to February 2020, which is the maximum number. And this is the ER protocol which we follow in our unit. So if there is any case of bronchiolitis present, so initially we will have initial stabilization and then classify as mild, moderate, severe. So for mild, we'll start with hypertonic saline and nebulization with adrenaline. And if there is response, then we can observe and then explain the signs. If there is moderate bronchiolitis, then we have to start on HFNC or CPAP and then continue with nebulization with either hypertonic saline and adrenaline. If there is severe, then we have to start on CPAP and then continue nebulization. And if the child improves, we have to continue respiratory support and monitoring. Not improved, then we have to think about escalation of support or even intubation. Thank you.